All right. Well, we'll get going then. Welcome to Spring 2024, North Delaware Mini Medical School. This series is a partnership between the Academy DPHA and our colleagues at Christiana Care. Here are the URLs for MiniMed and also Christiana Care. And I do encourage, many of you are sending questions about where can I watch the videos or where can I get the PDF of the presentation. All of that's at DelawareMiniMed.org. Whoops, social media tags right there. We're on LinkedIn, Instagram, Facebook, and Twitter, or X as it's called. You all by now should know about the program. We were founded in 1930. MiniMed's been running continuously since 2009. These series are offered as a part of the Delaware Health Force Initiative, which is a public-private partnership between the Academy DPHA and the state of Delaware. There are no tests or grades. There will be at least 3 other series happening during 2024. For those of you who are professionals, sorry to say there is no continuing medical education. There's no CE for this. If you're here, it's here on your own recognizance to do adult learning, but with no particular kind of credit for it. Participants attending all 6 sessions live will attend a certificate of achievement, and new this year, if in fact you miss a session, you can make up with no particular kind of credit just for let me participants attending all sessions. Turn off that echo. You can miss one session, make it up by viewing it at DelawareMiniMed.org, and then send me tgibbs@delamed.org an email letting me know that you've done a makeup, and I will ask you a couple of simple questions just to validate that you have in fact seen, but you can only do that with one session. For those of you who are watching on YouTube Live, you must email tgibbs@delamed.org and let me know that that's how you're participating tonight. So why do we do this? We want to increase and enhance health literacy in our community. We want to expose the middle, junior, high school, undergrad, grad students about all the different types of careers and degrees that go into healthcare and public health and dentistry and research. Our presenters will talk about their career pathways to clarify how they got to where they are. And you have one very interesting story in store for you this evening. And then this is a safe place for students and the instructors to talk about the topic at hand for this evening. You're not going to get a shot. You're not going to get your teeth drilled. You're not going to get bad news from your doctor. But in the same stead, please don't ask any personal medical questions or talk about those of family members or friends. That's a violation of privacy. Housekeeping tips, as always, this is a webinar, not a meeting. You can turn your video cameras off. There are over 1,000 students registered for the series. There aren't that many people who are here this evening or in any given session. However, we are providing this also on YouTube at Delamed 302, and then click on the video. Only use the Q&A feature to ask your questions. Nicole and I will be answering. That is also where you should ask questions that the presenters, will answer at the end of not one, but both presentations. We're going to try and address as many questions as possible, but we do have a hard stop at 8:30. Always the question, how long do I have to stay to get credit? You need to stay until the end of Matt Lynn's presentation. So Dr. Agarwal and Matt Lynn, and then you can cut out. A lot of good stuff usually happens in the Q&A. Covered all of that. Delaware Youth Medical Academy, you can learn more about that at DelawareMiniMed.org. The number of people who are members of the Youth Academy continues to grow, and that's fantastic. And so tonight we're talking about behavioral health, understanding addiction and anxiety, depression. This is going to be presented by Vishesh Agarwal and by Matthew Lind, one a doctor, the other one a physician assistant. So here we go for the introductions. Dr. Vishesh Agarwal is an inpatient psychiatrist specializing in addiction psychiatry. He joined Christiana Care from a nationally recognized behavioral health center where he worked with patients and care teams in the methadone program, buprenorphine, and comorbid substance misuse clinic. I should have practiced that in advance. He earned his medical degree from Wahati Medical College, completed his general psychology residency at the Einstein Medical Center in Philadelphia, and completed a fellowship in addiction psychiatry at the Zucker Hillside Hospital in Glen Oaks, New York. He is board certified in psychiatry by the American Board of Psychiatry and Neurology. Matthew Lind is a physician assistant within Christiana Care's behavioral health department. He attended Christiana Care Academy of Medicine Mini Medical School Series when he was a high school student at junior at St. Mark's High School, which helped solidify his interest in healthcare. He went on to complete his undergraduate studies at Philadelphia University in 2017 with a bachelor's in health sciences and a minor in psychology. He then completed his master's degree in physician assistant studies as Thomas Jefferson in 2019 and started his time at Christiana Care that same year on the inpatient psychiatric unit. Since then, Matthew has worked in the primary care setting with the integrated behavioral health team and is currently working in the outpatient psychiatry clinic at Wilmington Hospital. In 2023, he received a certification of added qualifications in psychiatry from the National Commission on Certification of Physician Assistants. During his time at Christiana Care, he has precepted physician assistant students and providers enrolled in the Psychiatric Advanced Practice Clinician Fellowship Program. He also provides psychiatric shadowing opportunities to interested second and fourth year medical pediatrics residents and primary care EPC fellows. So at this point, I'm going to stop screen sharing, turn it over to Dr. Agarwal for the first of the two presentations. Dr. Agarwal, over to you.
Thank you. Let's see, hopefully this will work. How does it look, Tim?
Perfect.
Hey, okay to go?
Yes, sir.
All right. All right. Well, thank you. Thank you, Tim, for that nice introduction. I was just looking at that introduction and remembered that when I joined Christiana in 2016, that's when I had entered those that information. Seems like stayed that way. Anywho, thank you for inviting us to this presentation, and I'm very excited to be here. And a large number of participants I see are online, 334 at this time, and I'm sure there's another bunch on YouTube or through the other social media channels. So that's awesome. I'm excited to share this presentation and my experience in medicine, and I also appreciate everyone taking the time from your evening to join us for this presentation. I'll try to keep things brief and try to keep you all engaged as best as possible. Just maybe like I'll spend a few minutes talking about my journey in medicine, which started in India, which is where I was born and raised. My family, I guess, is a family of physicians. So at this point, I think I have about 20 plus physicians in the family. And I was personally inspired by my uncle who went into medicine, and then my older brother who went into medicine, and he pursued psychiatry in the UK, and seeing his work and seeing his way of working, given that psychiatry and behavioral health in general, including substance misuse, carries a lot of stigma around Asian American and Pacific Islander population here. When I moved here, that was my decision to go into psychiatry as a specialty. Since then, I moved into addiction psychiatry as a subspecialty fellowship, And I also completed an obesity medicine fellowship in the past years. So that's just briefly about, where time took me and, where I'm now. And so given, that I have some experience working with individuals who struggle with substance misuse, I thought it might be worthwhile talking about substance misuse with all of you and just sharing, just some ideas around what that means. For students in school or undergrad, I think, when you think about substance misuse or just the curiosity about medicine in general, if things you hear, they make you curious, that would tell you that you may have, an interest in science or medicine, so, and that's why the title of the presentation I kept it like what, why, and when, like, if you ask those questions frequently enough, that would tell you that you would be a curious person. So moving on with the presentation, our title is Understanding Addiction, What, Why, and When. So just to elaborate on those, and let's see, my cursor moves here. Okay. Some objectives for the presentation today. What is addiction? We will review and discuss briefly the epidemiology, some statistics, and some definitions of substance misuse. Why or how and when do people get addicted? So we'll try to illustrate using some pictures or graphs on how addiction kind of evolves in individuals. And then we'll just review just, in a single slide, kind of some interventions, like just very high level, just to kind of touch base. And now my understanding from speaking with Tim and the Minimed team was that there's a younger crowd, so which means you're pretty active with your phones and social media. So I thought I might take this opportunity to see if we could have a survey or a poll. The question is, what do you think when you hear the term addiction? Do you think it's a brain disease or do you think it's a personal choice? The way to answer to the survey is either you scan that QR code. Oh, people are starting to answer. There you go. Or you go on slido.com and enter that number if you're on a desktop. And then you'll see the poll pop up and you can start answering. So I'll give maybe like 10 seconds or maybe a little more to see how people respond to it. And 80-20, so yeah, that's good. Again, repeating the question, like when you hear the term addiction or substance misuse, do you think it's a brain disease or do you think it's a personal choice? Okay. Well, I appreciate that people are still answering, but for the purpose of our presentation, I think I'll try to move along. I'll just take these percentages in. Yep. Okay. Well, thank you all, and yes, we'll get to this answer in a little bit, or I think the presentation itself might, give us some guidance on that. And then another question is, can you name some substances that you believe can be addictive? And this is a free word answer, so you could choose a word or a substance that you can think of, and we'll hopefully see that pop up. Alcohol. And if you see that the same answer you can tap on your cell phone or such. Good. Nicotine. Wow. Excellent. Coffee. Great. Sugar. Exercise. Very interesting answers. This is great. Oh, I see xylazine. Someone wrote xylazine. That's amazing. Yeah. Heroin, meth. All right. Thank you again. And I'll move on. I see some people are still typing, just in the interest of time. But I appreciate, and I see many of you or most of you have tapped on alcohol, which is great. And actually, alcohol is one of the more or most common substances that is misused around the world. Going into some, numbers for the United States. In the United States, based on our census data, what we also calculate is a survey called the National Survey on Substance or Drug Use and Health. So it's NSDUH, and it's done. The last one that was done in 2021 gave us some good, very helpful information about the prevalence of substance misuse. When we think of a scientific condition or medicine, in healthcare, whenever we think of a condition, we first try to put together the disease burden, or what we call, like, to lay the status of the problem or define that problem, and then we try to work on the solution, or so to speak, the treatment. So from an epidemiological standpoint, in 2001, based on the NSDUH data, 61.2 million people in the United States used illicit drugs within the past year. So that's about 22% of US population used some form of illicit substance within the past year when assessed in 2021. Marijuana was the most common used substance at 52.5 million US individuals using marijuana. Some more data was that more than 9 million individuals who were 12 years and older misused opioids. So when I say misused opioids, they used opioids either not from a prescription they own or not for a clinical reason. And then the 46.3 million, and which is what you see on the left side in the graph, is 46.3 million individuals 12 years and older met the criteria for substance misuse based on clinical definition. So more than 46 million individuals met the criteria for substance misuse, of which 29.5 million had an alcohol use disorder, more than 24 million had a drug use disorder, and there's some overlap, which is why the total is 46.3. And the one other concerning statistic was that the highest percentage of use was found in young adults between the age of 18 and 25. Now, there was another very alarming piece of information that was found, that of these individuals who were diagnosed with a substance use disorder, which is the 46.3 million, 94% of those individuals did not receive any treatment at all. So either they did not seek treatment, or they may have not had the means to get to a treatment that was available, or there was disease or the stigma that did not allow them to get to treatment. And so we are going to try to discuss, what are some things that we could do as individuals, as members of society. In our state, Delaware, this is data from 2022, where Delaware did ranked second in the country at one point in 2021 and 22 in the number of overdose deaths in the country. So second from the top in the number of overdose deaths per capita. And in 2023, I think the data was just released, we have seen a downtrend. The first time in 10 years, we have seen that there's a drop in Delaware total annual, like the total fatal overdoses in a year. And some of the reasons have been like the active intervention from the Department of Health and Human Services, and more specifically, the Department of Substance Use and Mental Health, and working towards reducing stigma, increasing screening for substance misuse conditions at every clinical encounter, increasing the education in the community and among healthcare professionals to provide treatment, making or creating more awareness around the treatment options available, and also improving the overall Delaware State's addiction treatment service system. So these have been some steps that they have taken. So this kind of sums up kind of the prevalence or kind of the epidemiology, I would say. And as you see the numbers, it is a huge problem. Now comes to like, what does addiction mean? Like, what is addiction? And just going into an historic context, Sigmund Freud, many of you may have heard the name. He was a neurologist who is also known as the father of psychoanalysis. And, he described addiction, and that is, how he described it is also how it is actually hypothesized even in current times. When we think of addiction, we think of addiction is a compulsive search for pleasure, and we still misunderstand it, that this is a condition that individuals choose to have. People who have addiction or substance misuse and are struggling are frequently stigmatized, and it is often considered that they can stop using the substance, but they refuse to do it. There's also, the idea that people who use illicit drugs or have drug substance misuse, they lie and manipulate those who are around them, and seems like they prefer pleasure against everything else, which does describe, these are some characteristics which describe several people who are sick with addiction, but it neglects the complexity of the disease. And I'm gonna take, I'm gonna take a shot at explaining that complexity to you in, as best as possible terms. So that's the historic context that, there was a lot of judgment and it is considered as a choice. But when we think of addiction again, like, there are individuals who smoke cigarettes and there are individuals who may drink alcohol, individuals who use marijuana, but not everyone or not each individual who uses a substance develops substance misuse or substance use disorder. So there are certain criteria, scientific criteria that have been developed that describe what entails the diagnosis of addiction. So when we say, like, is there a problem? Like, if someone is trying, once, twice, when does it become a problem? And there are certain criteria which are described in some categories and then subcategories. So if there is loss of control to their use, which can be described as increased amount of use or increased duration of use, there is a persistent desire to reduce their use, but it's failed, like they fail to reduce their use and they're consistently trying to reduce their use. They spend a lot of time thinking about using or actually using, and they have craving when they are not using the substance. So that's all these characteristics come in the loss of control. Social impairment. Oops. So social impairment is when they start to neglect their family, personal or occupational obligations. They may not show up at work. They may focus on continued use. They do not, take care of their family or their work, and they may lose their jobs, may end up with divorce or losing family ties. That's social impairment. Risky use. So individuals, if they start using in unsafe environments, if someone is drinking and driving, they are continuing to use despite having some medical sequelae. So, because of alcohol, they may have liver disease, but they may continue to use alcohol. And they know that it is risky because it can damage their liver further, but they still continue to use. So there's medical sequelae that they are ignoring. That's problem. And then pharmacologically, criterion are tolerance and withdrawal. What tolerance and withdrawal mean is, as an individual continues to use a substance over a period of time, their brain and their body, it starts to accommodate the amount of substance, which is why they end up using more and more substance, as you see here, the increased dose and duration. And that's the reason for that increased dose is because their body develops tolerance. Withdrawal, on the other hand, is the effect of the body not receiving the substance in the same amount. So over time, as people continue to use, their body gets habituated to the substance in question. And when they stop using or they reduce their use, their body gives them a negative signal because it goes through physical withdrawal and they feel uncomfortable, they feel anxious. And when that happens, it presents as withdrawal. So if criterion in this list are met, then we say that there is a substance use disorder, and they can be categorized mild, moderate, severe based on the number of criterion someone meets. Now, is addiction a brain disease? So, as I was mentioning in a previous slide, that the previous model or the understanding of addiction was that it is a behavior and it is a choice to seek pleasure. But in 1997, so that's about 27 years ago, Alan Leshner, he's a neurophysiologist who came up with this brain disease model of addiction. And this was the first landmark paper that researched actual brain changes leading to addiction. It was described in the journal Science, very reputed journal, And this is a newer version of the Science Journal. I have a cover of the original version, 1997 version, where it was published. This is how it looked back then. And the study that they published, some of those findings are shown on the right side. What they showed was a scan of the brain of control, meaning a normal person, normal individual. And the more colorful you see the red and the orange and the yellow, that's the blood supply in the brain. So normal human individuals' brain blood supply is as you see here. Someone who has used cocaine and has cocaine use disorder, you see there's a decreased blood supply, which means that there is physiologic and organic or physical change in the brain parenchyma, the brain matter, due to which there is reduced blood supply. And because of that reduced blood supply, the ability of the brain to process information, to make executive decisions is decreased, which is what leads to the development of addiction. So the landmark paper that was published in 1997 led to significant public policy change, significant more research and investment or funding into more scientific research to define define addiction as a brain disease. And that has led to also many new treatments that have come through over the past 2 decades. Just to go over how does that process work in the brain? Like what happens in the brain that leads to pleasure or that reward seeking or the development of addiction in some individuals. So as you see on the left, the picture, you see a slice of the brain or a side section of the brain. VTA stands for ventral tegmental area. The nucleus accumbens is known as the reward center of the brain, and the prefrontal cortex is known as the smart brain. Whenever an individual uses substance, so this is the reward pathway that is highlighted in the purple color. And the reward pathway is something that every individual has. It is a normal system that leads to motivation. When you have a positive stimuli or you do a positive act that gives you pleasure, you continue to do the act, which is essential for survival, and the reward pathway is triggered in that process. Some examples are, when you eat food, you feel good, water, sex, nurturing. These are essential acts that lead to evolution. And to continue human beings to evolve, when they do these activities, dopamine, which is the neurotransmitter in the reward pathway, is secreted into the nucleus accumbens, which is the reward center, and it gives a message to the smart brain that we need to keep doing this for survival. So that leads to that motivation, engagement, and survival. So I go to work every day. Every 2 weeks, I get a paycheck, and my prefrontal cortex tells me to go back to work on Monday. In a simple way to understand that. Now, also in the reward pathway, our brain has a protective mechanism, which is the stress response mechanism. So if things are not well, our amygdala gets triggered, and it tells us to be careful or cautious, which is the fight or flight response, which is also essential for survival. That if you see a wild animal, you'll try to stay away from it, and that's essential for survival. So this stress response leads to some other chemicals secreted in the brain, which cause some negative changes in the brain. And this is the normal reward pathway. Now, what happens when the reward pathway is disrupted by a substance that could be misused, as many of you named: alcohol, nicotine, heroin, opioids? So when an individual who has higher risk of developing substance misuse attempts or tries a substance, the reward that they receive is supraphysiologic, meaning it's a reward on steroids. So their brain gets the message that it was a super experience. That super experience gets recorded in the smart brain, and the smart brain then says, let's do this more. And when they keep doing this more and more, that smart brain, which was telling them to do more, now is hijacked by the same substance. So instead of controlling the amount of use, the smart brain tells them to use more, and it leads to what we call the pathways hijacked, and that leads to the development of a substance use disorder over time. When that happens, the individual's time is mostly spent on getting more and more substance because they need a higher amount of the substance to get the same effect, which is what we were discussing about tolerance. And also the amygdala, which is the stress response system, it starts to experience the withdrawal effects when they are not using. So again, the brain again and the smart brain, it focuses or spends most of their time to seek that substance because of that withdrawal effect. And that leads to them ignoring, obligations, um, job, personal, family, social obligations, and that leads them to be isolated more so. So that's what happens when the reward pathway is disrupted in an individual with substance misuse. Another way to look at it is like, some stages of addiction. And we're going to start with the binge intoxication phase up on top in the blue shade. There's persistent desire to use large and large amounts to get that binge or that high reward. And this is the area, basal ganglia, where the reward center is located. When they keep doing this over time, their reward sensitivity decreases. So for the same amount of use, they do not get that same reward. And when the reward sensitivity decreases over time, they start to have the withdrawal effect, and the withdrawal or the negative effect is what we were saying the amygdala, executes. And then they compromise their recreational social life. They will not go to their job, but rather go to the place where they can get their drugs or alcohol. And they continue to focus on that negative effect. At this time, they are not actually using to get that pleasure or that high, but they are actually only using to avoid that negative feeling, the withdrawal effect, which is not tolerable. And as the process continues, much of their time is spent in either obtaining the substance or thinking about obtaining the substance. And that is the preoccupation or anticipation of the smart brain, the prefrontal cortex. So the smart brain, which is executive function, which would have guided us otherwise, the executive function has now decreased and the focus goes to continued use. And this cyclical process leads to, over time, development of addiction. And addiction is the severe form of that substance misuse. As this process happens, there is change in the brain parenchyma, in the brain tissue itself. And as you see here, what is neuroplasticity? Neuroplasticity is that change in the brain tissue. It's the ability of the brain to reorganize itself, both in structure and how it functions. So there are new neuronal connections that are made as this process happens. So when people are continuing to use, they have loss of control, the reward center is involved. Over time, the smart brain is involved, and the negative stress response system is involved. And the neuroplasticity causes the brain to change and realign the focus towards that substance seeking rather than taking care of the normal and important things in life. And then that is what neuroplasticity is, and that is what describes the brain, the addiction as a brain disease. To understand this in a different manner, because there's so many complexities to when or how addiction develops, we also postulate a biopsychosocial model of addiction. And what that biopsychosocial model says is that there are genetic, there are biological, there are psychological, and there are social and cultural factors that result in substance consumption to begin with. There's not one reason why someone may use a substance. Teenagers, they may just want to try, and that's what is noted as novelty seeking behavior. Just maybe that curiosity. Sometimes there's peer pressure to try something new. What happens is when there are higher risk factors, that there may be a genetic predisposition because of family history, and because of the peer pressure, they may try the first time. The brain's reward pathways triggered supraphysiologically, meaning they get a very excess reward, and that leads them to trying the substance again. And over a course of time, they may risk developing substance use disorder. So it's not one or the other factor, but it's a combination of factors. And sometimes these factors can also be protective, that if they have positive family influences, they have a positive social support and emotional support, there might be more support that could be preventive to the development of addiction. And the reason why this is also important is that when we look at the prevention and treatment of substance misuse, these factors do play a role. The environmental factors, the genetic predisposition, what substance they are using, because based on that, the treatment plan would be determined. Looking at a tree of addictions here, so you see it's kind of similar to this biopsychosocial model where we say that there's several factors that may play a role into the development of addiction, and then there's this social and psychological factor that can perpetuate the use over time. So what can we do? Like, what do you think we can do about substance misuse? Like maybe to treat it, to prevent it? What are some things we can do? There's a lot we can do. At a community level, at a societal level, we can increase education, improve the awareness about what substance misuse means. One of those means of increasing education is something like MiniMed, where we are discussing this topic and trying to understand the complexities of substance misuse. This also helps when individuals understand the disease or the condition better. There's less stigma to seek treatment. When there's less stigma to seek treatment, there's a higher possibility that people may go and seek treatment sooner, or what I'm noted as early detection. With the education, when people know that there's a risk factor, if they were to try substances at a certain time in their life, there might lead to prevention of that substance use disorder to even begin. The other thing by reducing stigma is also that we have more effective and timely treatment, which leads to less negative effects in the long term. So it can be, the condition can be treated or contained early, and it leads to less physical and emotional damage over time. The other thing that can be done, and is at a legislative level or the government level. So in recent budgets, there has been a lot of focus on increasing the funding into treatment for substance misuse. So the increased funding should also be paired with what we call parity. So if someone has hypertension, that they can go to a doctor's office and they can get their medication for hypertension. Someone who has an opioid use disorder may not have the same availability because not every doctor may be treating opioid use disorder and may not be comfortable. So legislatively, if there is increased funding and there's availability of that treatment, that is what parity is, that every individual has the same opportunity for treatment. Removing barriers, one of the ways is to reduce stigma. The other things are to increase access to care where there is now none available. Harm reduction is one other focus on legislation. What harm reduction means is, when individuals are using substances and they may not be ready to stop using, the idea is that we can reduce the harm from the substance by providing them with some support during that time and help them understand the disease and help navigate them into treatment. This helps in saving lives, because if they were to continue to use the substance without any support, there's a high risk of overdose. So harm reduction is one upcoming feature in substance misuse interventions. Another thing is to addressing the illicit drug trafficking trade, which is a large source of the illicit drug market. So to address that, that's another approach towards treatment or interventions. This was the end of my presentation, and I was going to ask again, just based on the 20 minutes or so of our discussion or hearing this talk, what do you think about addiction as a brain disease or as a personal choice? And if you guys are still around, let's see if we can move the needle. So I have the last time before the presentation was 72% brain disease and 28% was a choice. So I think we're doing better here. Okay. Right, great. Yeah. I think I might have to convince those 4 people next time. Uh, well, thank you for hearing this. And we are going to get to questions after the next talk, which my colleague Matthew Lind will be presenting. And he has an interesting story of inspiration from the MiniMed program that he will share. And I'll pass it over to Matt. And thank you for listening.
Right. Just going to try to see if I can share my screen here and see if I can do that correctly. Let's see. Okay. All right. Does it look like we're
Perfect.
seeing? All right. We're seeing it. Good, good. All right. So my name is Matthew Lind. I am a physician assistant with the psychiatry department. So I do work in the same department as Dr. Agarwal. So the interesting story, I suppose, is that I did start back in high school about maybe 11 or 12 years ago as a student in the mini-med school curriculum. I do remember doing that in I believe it was my junior year of high school. It was all in person back then. And I recall that we had a limit of about 2 students in our class that were allowed to go. And I was very excited that I was able to go. And I would say that it was that particular class plus a psychology class that I took, plus this experience itself that really pushed me into wanting to pursue a career in medicine, particularly in psychiatry. That was always what my interest was in. And that was at, of course, with partnered with Christiana Care. I was at the main Christiana Hospital in the education center when I went for those 6 weeks. And so then several years later, here I am working with Christiana. So that was a very good experience for me, and very happy to be here to be on the other end of it. So my presentation is on understanding anxiety and depression. So some of my objectives are very straightforward. It is primarily talking about what is anxiety, what is depression, and reviewing what it means to have these things. What kinds of anxiety or depression disorders exist? How do we treat them? And then kind of throughout, because I wanted it to somewhat relate to Dr. Agarwal's talk as well, is I will mention little things about addiction or substance use kind of sprinkled throughout when it comes to treatments and when it comes to diagnosis or development of these conditions as well. All right, so what is anxiety? So the first half of this, I'm going to talk about anxiety, and the second half, I'm going to talk about depression. So anxiety is a term that gets used a lot. I would say these days it gets kind of tossed around a lot, but when you think about it, it's kind of hard to really define it easily. Some people would say it's fear, some people would say it's worry, some people would say it's just this sense of unease. So I do have a more casual definition up here, but a more formal or medical definition is kind of below that, where it's, in terms of what it says there, it's also this diffuse, unpleasant, or vague sense of apprehension. And it's often accompanied by symptoms such as like headache, tightness in the chest, stomach discomfort, restlessness, inabilities to sit still. And one of the big things is to look at anxiety as being something that's different than fear. They are often very much related to one another, but it is different. So anxiety is really a response that's future-oriented, it's long-lived, and it's broadly focused on a diffuse threat. Whereas fear is present-oriented, it's short-lived response, and it's to a clearly identifiable and specific threat. So why do we get anxious? So people can get anxious about nearly anything. It could be like an upcoming test, driving in bad weather, a job interview, being late for something like school, work, an appointment. And it's really important to understand that it is a normal reaction to stress. Mild levels of anxiety can be beneficial for us in some situations. It can alert us to dangers, and it can help prepare us and pay attention to things. It warns us of threats so that we can prepare, adapt, avoid, and prompts us to take necessary steps to prevent some kind of threat or reduce the consequences. So that could be that kind of push that we get to prepare for that test or interview, driving safely, preparing to leave on time for something. When it starts to become disordered is when these anxieties become excessive, beyond what is typically reasonable, and causes a lot of distress or dysfunction in daily living. It goes from being healthy and adaptive to unhealthy and maladaptive. So how do these disorders develop? Well, so there's a lot of different psychological theories behind this. Dr. Agarwal previously mentioned Freud and psychoanalytics, which also relates to psychodynamics as well. So I have here a little bit about the psychodynamic thought process, which gets pretty complicated, but boils down to it's a response to internal conflicts between unconscious wishes and desires, and that conflict between a corresponding threat from reality. And then we enact defense mechanisms to prevent unacceptable thoughts and feelings from emerging into conscious self-awareness. The behavioral theory proposes something that, at least to me, is a little bit more simple. It proposes that anxiety is conditioned or mimicked and learned. So, for example, an anxious child may see that their parent is very anxious to certain circumstances, and so they start mimicking that and having that same kind of learned response and behavior. Or it can go even further and be a child with an abusive parent might become anxious whenever they see that parent, and then eventually develop a generalized response to anyone with similarities to that parent. Perhaps if the father was abusive, then the child grows to mistrust all or most men or other people that remind them of their father. There are also a lot of biological causes or risk factors. So that's things like genetics, brain structure and activity, hormones, neurotransmitters. There's at least a major component going on with genetics. So there's a higher risk of developing an anxiety disorder when a first-degree relative also has an anxiety disorder. So that's like if your parents, your siblings, or your children have an anxiety disorder, there's a higher risk that you will as well. It's not 100% though, and almost half of patients with panic disorder, which is a specific type of anxiety disorder, almost half of them have at least one relative who also has that. And with the genetics, though, there's no specific anxiety gene or genes that follow simple inheritance. The genetic elements to it is quite complex. All right, so when we get to more the neurochemical processes involved in anxiety, we've got the autonomic nervous system, which is specifically here relating to part of that, which is the sympathetic nervous system, and that's what dictates our fight or flight response. So another thing that Dr. Agarwal mentioned was that fight or flight response in the amygdala. And so in those with anxiety disorders, there's an increase in sympathetic activity, making people respond excessively to just moderate stimuli. And that can lead to some of these anxieties' physical symptoms, such as elevated heart rate, headaches, upset stomach, diarrhea, fast breathing. Some of the neurotransmitters specifically involved in that fight or flight response and in other elements of anxiety disorders is neurotransmitters. The primary ones that I'm going to focus on here for anxiety are norepinephrine, serotonin, and GABA. GABA I'll have on the next slide. So norepinephrine plays a major role in the fight or flight response. Those with anxiety disorders may have poorly regulated system involving norepinephrine, leading to symptoms of insomnia, high startle response, or other fight or flight responses that I mentioned before. Serotonin is another big one with anxiety, and as I'll talk about later with depression, serotonin is a big one there too. So during times of high acute stress, there's an increase in serotonin turnover, especially in parts of the brain that we know deal with processing our surroundings based on past events, fear responses, and emotional processing. And all first-line medications for the treatment of anxiety disorders are generally serotonin-based or serotonergic. And we even see that there are certain drugs of abuse or substances that are serotonergic as well, such as stimulants or LSD or hallucinogens or stimulants such as MDMA. And these are often associated with the development of an acute or even a chronic anxiety disorder. A little bit here about GABA. So GABA is a major inhibitory chemical in the brain. So it's responsible for slowing activity in the brain by blocking certain signals in the central nervous system. Its involvement is strongly supported in the theory of the neurotransmitters being involved in anxiety because medications known as the benzodiazepines are known to alleviate acute anxiety. And then medications that were counter to that, benzodiazepine receptor antagonists, can cause severe panic attacks. When it comes to hormonal processes, two main hormones that I wanted to focus on here are cortisol and corticotropin. So these are really our stress hormones, so especially cortisol, which, as it's supposed to work, it mobilizes and replenishes energy stores during our fight or flight response, especially. And it increases arousal, vigilance, attention, memory formation. And then the corticotropin releasing hormone helps coordinate the adaptive and behavioral physiological changes that occur during stress. All right, so here I have just a graphic of the DSM-5 diagnostic criteria for generalized anxiety disorder. So that's kind of our main guide for how we diagnose generalized anxiety disorder in a clinical setting. Now, this is just one of many anxiety disorders. The anxiety disorders in general are the most common among the mental disorders, with generalized anxiety disorder being the most common of them. Generalized anxiety disorder is often what people think of when they talk about being treated for anxiety or having an anxiety disorder. But some of the other ones can include panic disorder, which I mentioned briefly earlier, specific phobias, agoraphobia, social anxiety disorder. But then there's also substance-induced anxiety disorders or anxiety symptoms that are the direct result of substance use. And of note, many people who suffer from anxiety disorders also self-medicate with substances and have co-occurring substance use disorders. So speaking now generally to generalized anxiety disorder, I mean, you can read what the main criteria here are, but it's primarily characterized by an excessive worry about several events or activities for most days during at least a 6-month period. That worry is hard to control. It has physical symptoms, it's distressing, and it leads to impairments in multiple areas of one's life. So, a little bit more about generalized anxiety disorder. So you can read some of the statistics that I had listed here. So it is more often diagnosed in women than in men, about 2 to 1 prevalence there. It's very common for people to have another mental disorder as well when they have generalized anxiety disorder. In fact, that is usually either another anxiety disorder or a depressive disorder, which I'll also talk about later with depression when I talk about that. In fact, it's about most patients, about more than half who have another co-occurring condition. It's common in adults and adolescents. Many do recall being anxious for most of their lives or about as long as they can remember. Patients who are seeking out treatment for anxiety or are getting diagnosed with it are, statistically speaking, most likely to go to their general practitioner. So their primary or family medicine provider, their pediatrician, and it's usually for a physical symptom. It's not necessarily for anxiety, but they're going to their doctor and saying, hey, my heart rate just keeps picking up all the time, and I don't know why. I'm getting this feeling like there's this pounding against my chest. Like, am I having a heart attack? Is there something wrong with me? And after some of those severe or acute medical things are ruled out, or more important or detailed history taking is done and screening is involved, maybe some tests, images, or blood work is done, they may come out with that and say, I think this might be generalized anxiety disorder. Now, it doesn't happen that every single time they're doing tests and everything like that. It really depends on the context of what someone's coming in for. But generally speaking, one of the important criteria with generalized anxiety disorder, and in fact, most mental health disorders, is that it can't be attributable to another medical condition. So that's why I use that in that example. So some people will accept a generalized anxiety disorder diagnosis from that, or they'll accept a referral to see either a therapist, a psychologist, or a psychiatrist. But others will seek out additional consultations for their symptoms. Maybe they don't think that that's correct, and they'll go and see a cardiologist for their heart palpitations. And in fact, only about a third of people with generalized anxiety disorder actually end up seeking psychiatric treatment. So generally, the onset of the anxiety disorder usually is associated with some kind of negative life event, although not always. And then the prognosis of it, so how they do long-term, can be very difficult to predict in generalized anxiety because it has so many other co-occurring conditions. So someone with, say, generalized anxiety disorder and social anxiety disorder may have a little bit of a better prognosis, say, than someone who has generalized anxiety disorder and schizophrenia, for example. So it's very hard to look at what that prognosis looks like because so commonly having another condition. It is by definition a chronic condition because it's lasting at least 6 months, but it can very well be a lifelong condition that people suffer from. All right, so how do we treat generalized anxiety disorder? So there are many different formal treatments that are done in professional settings, primarily medication or therapy. And so I'll talk here a little bit about therapy first. So there's a whole slew of different types of therapies. I'm going to really just focus on 3 here. And as you'll see here, this is particularly useful for people who are motivated to understand their anxiety and are psychologically minded. So a lot of times therapy it's a commitment. It can be a lot of work, depending on what type of therapy it is. And for some people, that's not feasible, or that's not something that they're interested in, or they don't want to open up to someone. And sometimes starting with just a medication might be a better alternative for them. Generally, for more mild or moderate forms, either one is okay. Very often we say that a combination of both medication and therapy is better than either one on its own. But again, it kind of depends on the severity and the given circumstances of that individual. So when it comes to psychotherapy, we've got cognitive behavioral therapy, which is probably the one that you may hear about the most. It's also called CBT. That's both short-term and long-term in terms of the benefits that people have. It's the most sophisticatedly studied in terms of treatment for generalized anxiety disorder. It addresses negative thought processes or cognitive distortions, and it challenges them with behavioral approaches such as relaxation, which are especially helpful for the physical symptoms. Psychodynamic therapy, the focus or the end goal for that might be a little bit different. It might be more so on understanding that anxiety can increase over time, and so focusing on increasing tolerance to anxiety. How do we identify that we're feeling anxious? What can I do to feel better about that? And, to an extent, how do I become comfortable with this and understand that this is just a part of my normal experience? Then there's also exposure therapy, which more often used for phobias, but I thought it was an interesting one to add here just because of how specific this type of therapy is. So it's a type of behavioral therapy, and it's about gradual exposure to the anxiety producing situation, the object of their fear, to eventually lead to desensitization. And one of the really interesting things of where this is going these days is instead of having someone go and say someone has a horrible phobia of spiders and to the point where it's hard for them to leave their home or to go to certain places for it, it's really, really affecting them. Well, instead of having them have to actually go and expose themselves to literal spiders with these days there's some virtual reality that people can have, and that can kind of help lead to an increased exposure, and can even for some types of phobias that are harder to replicate in an office setting. And so that's something that's really new and upcoming in treating phobias, so I thought that was an interesting one to add here. All right, so then there's the medications for anxiety disorder. So medication management is primarily what I do in my clinical practice. I would say anxiety disorders come up with the vast majority of the patients that I see. And so these are medications that I am managing multiple times a day. And even these are just a snippet of what's available out there, but these are the most common and first line medications. So these primarily work on serotonin, norepinephrine, and GABA, which are the ones I described before. So the SSRIs, or selective serotonin reuptake inhibitors, are the first line medications. They're also commonly referred to just as antidepressants, but someone does not have to have a depressive disorder to be on an antidepressant. They could have just generalized anxiety disorder, and this type of antidepressant would be perfectly appropriate for them. And so we've got a couple of different classes here there's the SSRIs, and then the kind of what I often refer to as almost like the cousin of the SSRIs, which is the SNRIs. So instead of just working on serotonin, they also work on norepinephrine. And so we see some different medications here that maybe some of you might even be familiar with, either by their generic name or their brand name here. So especially Prozac and Zoloft are pretty commonly talked about. And Cymbalta, I know, is one that gets used for a lot of other reasons too. That one even gets used for chronic pain a lot. So some of the advantages of the SSRIs and the SNRIs is that they work really well for people who have co-occurring conditions, especially depression, other anxiety disorders, obsessive compulsive disorder, or OCD. So you're getting a lot out of one medication to maybe treat multiple things. And as I said before, people with generalized anxiety disorder tend to have multiple other conditions too. So that makes these a really good choice. They're also really safe medications, especially compared to the older generations or some of the potentially addictive medications. And so that being said, there are some disadvantages. Any medication has pros and cons. So some of the disadvantages are they can take up to 4 to 6 weeks to have a full effect. Sometimes that's longer. Sometimes some of them can temporarily worsen anxiety before improving it, especially if that individual medication is very stimulating or if the person taking it is very sensitive to medications. There are some people who these medications don't work for as well, sometimes leading to a little bit of trial and error. So maybe they have tried Prozac and then Zoloft, and now they're on Effexor. And so that can then lead to some delays in their improvement. Medications in general, these types at least are usually used for 6 to 12 months at least to get a good sustained response. But in many cases, it's longer than that. In some cases, it's even lifelong because, like I said before, anxiety is a chronic condition that can be lifelong. Okay, so now the other medications are the benzodiazepines. So these are medications like Ativan, Klonopin, Xanax, Valium. These are medications that work really well for anxiety. They work by promoting GABA, which is that major inhibitory neurotransmitter that I mentioned before. They work really fast, within minutes to less than an hour, and they can be taken on an as-needed basis. So that makes it a lot more attractive in some ways than a medicine that is maybe taking 4 to 6 weeks to take effect. The downside to that, though, is that they can lead to abuse, intoxication, risk of overdose, tolerance, dependence, and addiction. Withdrawal from these in smaller severity, so if it's more mild withdrawal, can lead to some worsened anxiety, which can then be someone mistaken that as their underlying anxiety returning, leading to a cycle of them more frequently taking the medication, increasing their dependence and tolerance, very similar to what Dr. Agarwal was mentioning before with that cycle. One of the big problems with benzodiazepines, though, is that severe withdrawal can be so serious that it can lead to seizures or even death. So as such, they are usually reserved for short-term use only, such as when an SSRI needs to take effect, for breakthrough symptoms, for rare or occasional panic attacks. They are sometimes used to also treat alcohol withdrawal, which is very similar to benzodiazepine withdrawal because they both have a lot to do with those GABA receptors. And that using a benzodiazepine for that alcohol withdrawal treatment can help prevent those severe consequences of alcohol withdrawal, like seizure or death, because again, those withdrawals of alcohol and benzodiazepine can be very similar. All right, now moving to the next part, which is depression. So again, kind of like what I had for anxiety, I have here so casual and medical definition of depression. And with this, I'm going to get even a little bit more into the woodwork with definitions. So because depression is something that also I think gets tossed around a lot, and it can mean a lot of different things to people, but it is more than just an emotion. Just like anxiety, I said before, is more than just fear or worry. Depression is more than just feeling sad or down. It's a complex and serious condition that has profound impacts on one's daily life. So depression is a mood or a mood disorder or a subset of mood disorders. And so we can define mood itself as a description of one's internal emotional state, which can be triggered by both internal stimuli, so like thoughts, feelings, and external stimuli, maybe stressors going on around you. Different moods can be things like being sad, happy, angry, irritable. And it's just like I said before, anxiety is a normal thing for people to have. Having different moods or a wide range of moods is very normal, and it's normal to have a sense of control over one's mood. But again, as I said before, with anxiety, it does become disordered at some point with these conditions, and that's when there's a lack of control and the mood goes beyond the range or severity that is typically experienced. So maybe no longer feeling sad or down about something, but now it's beyond just that. You're not feeling sad or crying about something, but you're not getting out of bed anymore. That video game that you were playing all last week that you were loving, having a great time, that doesn't really interest you anymore. And so also with depression, we've got depressive episodes and we've got depressive disorders. So the depressive episodes are the distinct periods of time during which there's clinically significant depression present. And these are often abnormal or different from what one's baseline is, so when they're not depressed. The disorders are the patterns of those mood episodes during which there's alterations in one's mood and return to a relatively normal baseline and functioning. Episodes can be triggered by all sorts of things, by events, substances such as drugs or alcohol, medical illnesses, underlying biological processes. Most of the time, the episodes are unpredictable, and the returns to baseline, so when they're no longer depressed, can be short or long-lived. There can be a chronic return to baseline, so someone might be depressed for a few weeks or a few months, and then they're good for the next 2 or 3 years or even a decade. Or they might only feel better for about 2 weeks and then they're depressed again. There can be a very wide range in how this goes, and it can end up becoming a chronic relapsing and remitting condition. All right, so what causes depression? So you're going to see here that there's a lot of similarities between anxiety and depression in terms of risk factors, the causes, even like the theories behind them, and then the treatments as well. They're, as much as they are different in terms of their definitions, in many other ways, they're actually very, very similar. So some of the things I tried to highlight were some of the nuanced differences. So psychosocial stressors can be a big predictor of a depressive episode. They often precede the very first episode that someone has of depression. And then they don't always occur for those other episodes. Things could be going very well for someone, and then out of nowhere, they just start slipping into a depression. And some of that might be that because stress led to some long-lasting changes in the brain, leading into alterations in neurotransmitters and intraneuronal signaling systems, thus leading to risks of subsequent episodes, even without a stressor. Certain personality traits might put someone at a higher risk of developing depression. particularly if they have a personality disorder. And then people with certain personalities may experience a stressor as reflecting negatively on themselves and affecting their self-esteem. So again, some similar schools of thought here. We've got the psychodynamic and then the cognitive behavioral models here. So with the psychological theories, what might be a mild stressor to outsiders might be a devastating thing to a patient who's suffering from depression due to partial meanings attached to the event or to developed coping skills or defense mechanisms that they've had over time. So with the psychodynamic theory, that's kind of boils down to there's a link to real or imagined loss of some sort, whether that's a loss of a relationship, even an object. And so that real or imagined loss then interacts with the unconscious mind, which then has to cope with that loss, and it turns that towards self-directed anger. And it sets it to the point where there's a discrepancy between extraordinarily high ideals and the inability to meet those ideals. And when certain needs are not met, there's a massive loss of self-esteem leading to depression. Some of the cognitive theories are a lot more different from that. So that's that there's cognitive templates in how one perceives internal stimuli and external data, and that is altered by early experiences, so such as in childhood or adolescence. And oftentimes these templates lead to thoughts that are behind the emotional state. So if I am feeling sad, there's usually thoughts going through my head that are making me feel sad. Those at risk for depression tend to have a triad of cognitive distortions with the self, the environment, and the future. So with the self, they have a negative self-image. With the environment, they tend to view the world as demanding and hostile. And then with the future, there's an expectation of failure or suffering. And so then that kind of leads into something called learned helplessness, which if you're not aware of that, that's something that can be depression resulting from uncontrollable events. So you might even be able to think about that in your own life or in something, or someone that you know. But this is like a conditioned response when people learn that outcomes are independent of their responses. And so they have a cognitive, motivational, and emotional deficit and become helpless and do not respond to trying to change their environment. They feel stuck. They start wondering, what's the point? It's more often characterized, should I say, by an example that kind of coined the learned helplessness term, which is an experiment with two groups of dogs that they had. And one group of dogs was the experimental group and one was the control group. So the experimental group was exposed to these electric shocks, and those shocks were then introduced to the dogs, and the dogs would of course try to escape from that. But no matter what they did, the shocks just kept coming. And then the control group, those dogs weren't exposed to the shocks. So then when they put the two different groups of dogs into these kind of platforms where there's a barrier that they could jump over and avoid the shock, the dogs that had developed learned helplessness realized that nothing that they did made the shocks go away, so they wouldn't even try to jump over that barrier. Whereas the dogs that had never developed that learned helplessness, they're going to try everything. So they jump the barrier and they don't get shocked anymore. And so that relates to humans and with that theory of learned helplessness, that no matter what I do, I'm still going to feel this way. I'm still going to be stuck. And that's where a lot of that feelings of guilt, feelings of burden, and low motivation come from in people with depression. So what causes depression in terms of biology? Very similar neurotransmitters to anxiety, specifically norepinephrine, serotonin, dopamine, dopamine being a different one here that I didn't mention with anxiety, but Dr. Agarwal did mention before, and that affects pleasure, satisfaction, motivation. And it's thought to be reduced in depression. And there is a greater prevalence of depression in other disorders and medications that lead to reduced dopamine activity, such as Parkinson's disease. There's a lack of dopamine in that, and there is a higher rate of depression with those individuals. And that is thought to be one of the reasons why. There are also hormones involved with this, especially stress hormones and how long-term effects of those stress hormones that I mentioned before, like cortisol, and how long-term effects affect brain development. There's thyroid hormones, and those with underactive thyroid hormones are often experiencing depressive symptoms. And so they might go to their general practitioner, like I mentioned before, with anxiety and say that they're very down, they're fatigued, they don't have a lot of energy or motivation. They get some blood work done, and it turns out their thyroid's actually not functioning properly. And so that would be a case of like a medical cause of depressive symptoms as opposed to an actual major depressive disorder. There are some neuroanatomical things that we see. So on brain imaging and studies where there are changes in the brain, especially in parts of the brain associated with emotional processing and memory. This can be in response to depression, or it might be predisposing one to have depression, or it might be a little bit of both. Maybe they have some of these changes in their brain already. This inciting event happens. Now they've had a depressive episode, and then that has done more damage to the brain, and now they're more likely to go into those depressive episodes. In terms of genetic causes, genetics definitely play a big role, as it did with anxiety, but not the whole role. So it's elevated if a parent has a mood disorder, any mood disorder, that someone may have depression. It's even greater when both parents have it, which makes sense. Twin studies, so when they compare identical twins to one another, indicates that genes explain only about 50 to 70% of the etiology of a mood disorder, which means that that other 50 or 30% is coming from somewhere else, like the environment. And that's where all those stressors I was talking about come from. All right, so as with generalized anxiety disorder, I had that as kind of the main disorder that I was going to focus on as the main anxiety disorder that people often think about, or is the most common one. I'm focusing on major depressive disorder, which is usually what people are referring to when they say that they have depression. Not always, but it is also what people usually refer to as clinical depression. There are other types of depressive disorders, some of them that mimic major depressive disorder by quite a bit. And some of those other disorders are things like persistent depressive disorder or dysthymia, adjustment disorders, bipolar disorders, which themselves can have major depressive episodes that are identical to someone with major depressive disorder. But in bipolar disorder, there's also the presence of mania or hypomania. And then there's cyclothymic disorder, where people have somewhat reduced severity depressive episodes and somewhat reduced severity hypomanic episodes, and kind of going through mood swings of those. And then there's also substance-induced depression, where a substance itself causes depressive symptoms. So think of the sedating or the depressant medications or drugs out there, like the benzodiazepines, alcohol, opioids, can cause a lot of depressive symptoms. And then even the withdrawal from some of those substances can lead to depression. So withdrawal from cocaine or the amphetamines, those can cause a lot of depression that tends to vary in how severe it is and how long it lasts, depending on how severe that abuse was and the withdrawal is. So then with major depressive disorder, some of the key elements here beyond what's on this slide are, or in addition to that, should I say, is primarily it's 2 weeks or more of 5 or more of the symptoms that are listed here, one of which must be either depressed mood or lack of interest or pleasure. It can be both, but it has to be at least one or the other. So there are people out there that experience depression without the classic sadness, hopelessness, crying. Like they're not necessarily feeling down or depressed, but they're just not feeling anything positive. And the things that once brought them joy, like I said before, there's that video game that you really liked, it's now doesn't really mean anything to you anymore. It's often, though, characterized by people feeling hopeless, in the dumps, feeling worthless. It can be described as agonizing emotional pain, a reduced ability to feel positive emotions. Sometimes, like I said, people are unaware of their depression, and loved ones are the first ones to notice. There can be a lot of reduced energy, motivation, or sleep troubles, poor concentration, or appetite changes as well. So a little bit more statistics with this. Like with anxiety generalized anxiety disorder. It is more common in women than men. Sometimes that is thought, however, that women may just be more likely to seek out treatment than men. The average age of onset is around 40 years. About half develop between 20 and 50, but it can still occur at all ages, in childhood or in older years. There is an increasing rate in younger people under the age of 20 developing depression, and that is thought at least in part due to alcohol and substance abuse, which, as I said before, can cause some depressive symptoms by the nature of their chemical effects, but it's also likely due to some of the long-term damage and changes it does to still forming brains. Depression is an isolating illness, and so understandably it affects those who are more isolated. So it's more common among those without interpersonal relationships, those who are divorced, separated. Commonly occurs with people who abuse alcohol, people with obsessive compulsive disorder, with anxiety disorder. Of all depressed patients, so not just in major depressive disorder, anxiety is a common complaint in up to 90% of depressed patients. So again, a lot of overlap between these two. With course and prognosis here, so there are some early warning signs for about half of the people with major depressive disorder with pretty major symptoms before they have the full syndromal episode. The early identification and intervention may help prevent the development of a full episode. When it occurs at late ages, we usually don't see as much of a family history of mood disorders, although we can. Or in those older ages, we see people that are maybe more likely to have a personality disorder or abuse alcohol. And while it is at least 2 weeks for it to count as a major depressive episode, most are far longer, most being about 6 to 13 months. Treated tends to last about 3 months instead, but that depends on a lot of different factors. It depends on what the treatment is, how severe it is, did they have to be hospitalized for their depression? And also remember, this is a complex condition with many symptoms and neurological processes. And so when we get to medications, we'll talk about how those do work fairly slowly. And so that 3 months sounds like a long time, but compared to 6 or 13 months, it's still pretty good. And these are just kind of ballpark numbers for different people. There are those who get better a lot faster than that. There are people who, without treatment, get better. It depends on the individual and many other factors. In general, though, stopping antidepressants before 3 months has passed is highly associated with the return of symptoms. And like with anxiety treatment, it's usually recommended that 6 to 12 months of treatment be continued, if not indefinitely. Relapse rates in general are lower in those who have continued their medications and in those who have only had 1 or 2 episodes. So those who have more frequent, longer episodes or longer episodes over time with less episodes in between is a sign of a poor prognosis. And like I said before about severity, that affects recovery. So if it was so severe that it needed hospitalization, it might be associated with a lesser chance of recovery or a less optimal chance. Some of the prognostic factors are having a mild episode, shorter hospital stays, solid friendships, stable family functioning, good social functioning, absence of another co-occurring psychiatric condition, especially a personality disorder. Advanced onset of age is a good risk factor. And then the lack of psychotic symptoms. So psychosis is not one of the main criterion that I've mentioned, but hallucinations and delusions and other psychotic features can actually occur in a severe depressive episode. Some of the negative risk factors are also having persistent depressive disorder on top of major depressive disorder. So that's like having a baseline of depressive symptoms that has deeper dips into depression, sometimes called double depression. Use of alcohol or drugs worsens prognosis, having anxiety disorder symptoms, having multiple past episodes, and in general, men tend to be more likely to experience chronically impaired course. One of the other things I wanted to add a little bit because of the audience that we have here was just child and adolescent depression. However, that is also something that presents a little bit differently for a lot of folks, as opposed to with anxiety, which does have differences, but with depression, there are some very specific differences. And so with child and adolescent depression, there's very often problems in school. And in fact, it's almost always something that comes up in school. And it's really only the highly intelligent or school-oriented children with no more than moderate depression who tend to be able to fully compensate for their difficulties in learning by sustainably increasing their time and effort. Learning difficulties are very common and are often corrected very rapidly after recovery from a depressive episode. But until then, sometimes, especially kids, are misdiagnosed as having a learning disability. Otherwise, as I said, school is almost always affected due to poor concentration, lack of interest and motivation, school phobia, skipping school. And then regarding substance use, it's common to have a family history of alcohol use and mood disorders. High percentage of adolescents with depressive disorders were actually first evaluated for their substance use instead. Okay, so it would be hard to talk about depression without mentioning suicide and suicidal ideation, which are very common complaints in especially the severe forms of depression. But please note that this is such a heavy and complex topic that it would be an entire talk all on its own to go into. But depression does account for the vast majority of suicide deaths, but a substantial portion are attributed to other conditions such as schizophrenia and dementia. Generally speaking, men are more likely to die by suicide and women are more likely to attempt suicide. And some of that has to do with lethality of means. Men statistically are more likely to use quick, irreversible methods such as firearms, hanging, or jumping from high places. Women are more often associated with using more reversible or slower means such as ingestions or overdoses. There are some different risk factors. So based on people's age, gender, race, religion, that can play different roles in suicide, attempt, or death risks. And then there's also things like people's social status can also indicate a risk. So those with high social status or major drops from social status are at higher risk. For example, physicians are actually a really high risk group, as are those in law enforcement. Okay, so treatments for depression, very similar to what they were for anxiety. That's because of the similarities in the theories behind them and the neurotransmitters with them. The main difference that I wanted to talk about with therapy was interpersonal therapy, which is something that is also pretty good for more mild to moderate episodes of depression. And that tends to focus on one or two of a patient's current interpersonal problems and focusing on that. Because like I said before, it's a very isolating illness. So focusing on those relationships can be very helpful for someone's recovery. For medications, there's the SSRIs or SNRIs that I mentioned before for anxiety. There are a lot of other classes of antidepressants too, bupropion, mirtazapine being others, which work on some slightly different neurotransmitters. So bupropion doesn't actually work on serotonin much at all. It's mostly dopamine and norepinephrine. And then there's the older agents. So there's the tricyclic antidepressants or the monoamine oxidase inhibitors. They don't get used as often, but they still do get used. They have their place, but they tend to have a lot more toxic effects or high side effect burden. With the MAOIs, people have to actually follow a very strict diet or else they can have very severe consequences interacting with that medication. And then just some other treatments that are non-medication related that I thought would be interesting to mention are just some of the neuromodulation treatments. So ECT using short electrical bursts to induce a small controlled seizure is found to be extremely effective for depression, but it can have a number of side effects such as headache, soreness, confusion, amnesia, but it's actually a very safe procedure. Then there's TMS, which uses short pulses of magnetic energy. It's kind of similar in terms of how it works to ECT, but instead of using electricity, it's using magnetic pulses to depolarize the neurons and stimulate them. Much better side effect profile. And then there's vagal nerve stimulation and deep brain stimulation, which honestly I don't see a lot of. But those are often used for other neurologic conditions and found to have pretty profound antidepressant effects as well. But they're much more risky and invasive procedures. And that is where I'll end.
All right. Thank you very much. Hold on for a second. I need to see whether I can't organize some windows here. Okay, so at this point, we can go ahead and take questions in the Q&A.
I have a list of questions that I took note
All
of.
right, Nicole, go for it.
Yeah, so we can maybe do one for Dr. Agarwal and then one for Mr. Lind and kind of switch off, or whoever wants to answer can take the wheel on that. So starting with Dr. Agarwal, it seems that an accidental exposure to the right substance could lead to SUD. Is that so?
So, like, I'm not sure if like how we would mean accidental exposure, but I guess and the right substance, I think it's more complex than just the question that is being asked. There would be preemptive factors that can increase the risk. One single use, at least I don't know, and I'm not aware of a research or body of evidence which tells us that a one single time use of a certain substance could lead to the development of addiction. But the process could certainly be possible that it could start, given that what we were discussing, someone who experiences that reward may seek to go on to use that substance. So I'm sorry, I don't have a better answer, but it is a possibility, but somewhat, more complex to answer.
Okay. Mr. Lind, could alcohol or smoking be seen as genetic or hereditary? I guess they mean like the addiction of drinking and smoking.
How do you mean by could that be hereditary? Like developing
I
like
think, yeah, an addiction to like alcoholism or for smoking. I think that's what they mean.
I mean, I think that's probably something that probably is more in line with Dr. Agarwal's presentation, but I would say, I mean, yeah, there is probably there is a hereditary component to that with that biopsychosocial model he was talking about.
And I can answer that as well. Like, so there has been a significant body of research on alcohol use, more specifically, where they show that children born to parents with alcohol use can have 4 to 6 times the risk of developing alcohol use disorder. And, they have done more studies on twins where both twins were separated, but they still developed alcohol use despite the environmental factors could be protective. So there's significant hereditary transfer of that risk of substance use disorder.
Okay, thank you. Yeah, so I guess since that went to Dr. Agarwal, we can go back to Mr. Lind. I was just dividing it based on the order it came in for presentations.
Yeah.
I guess this goes back to like the chicken and the egg. For anxiety disorders, is the causative driver nature or nurture? So innately biological or learned response?
I would say it's both. I think there are people that probably have a much more genetic component where despite their environment being pretty stable or not having stressors, they still have that anxious temperament. And then other people who have a pretty calm, easygoing demeanor, who go through a lot of stressful events, who they might not develop a anxiety disorder. So it's almost like your genetics are your risk factors, or it's almost like if you think of it like a broken window, and the window's cracked based on like your genes and then the environment. And some people might have a little bit of a weaker window that breaks over time, and then it's the development of that depressive or anxiety disorder. But some other people might have maybe a little bit of fewer cracks in the window, or their window's just made of a bit stronger material, and that's just how individuals are based on those differences that they have.
Next question. This one's, I guess, kind of interesting. Dr. Agarwal, you mentioned stigma reduction.
Mhm.
But how exactly can an individual work on that, especially if it is often cultural?
Oh, that's a very good question and a tough one, I'd say.
Yeah.
I come from a culture where, there's significant stigma associated to behavioral health in general, substance misuse. Um, I believe the one thing that can have value is the education. Um, the reason for stigma sometimes is lack of awareness and lack of education sometimes. There could be that cultural component to it, but I believe that education to people in the community, that there is that stigma. I think having some community events through their organizations, if it's a religious group or association may help.
Yeah, great. Mr. Lind, if a friend is dealing with an anxiety attack, what are some ways I could calm them down? I don't know if there's some techniques or strategy people could learn.
Uh, Probably not something I could share in just a couple of seconds as an answer, but I would say the first thing is to be as patient with them as possible and to be as empathetic with them as possible. Understand that when someone is going through an anxiety attack, their brain is processing information a little bit differently than yours is. It's probably kind of on hyperdrive and they're hypersensitive to things. So being very calm, courteous, and just kind of being there for them is one of the most important first things so that you're not kind of exacerbating that any further. Certain things like behavioral activation can be helpful. So maybe that's going for a walk, or even things like taking slow, deep breaths can be helpful to start. Drinking water can be helpful because it's something that you have to do kind of very slowly and very sequentially. There are things that are online that are pretty useful tools to look up, like grounding techniques or mindfulness. Those are all things that are pretty helpful for that. But I'd say the first and foremost is being patient and non-judgmental.
Yeah, no, that's awesome. I think some people, when someone else is panicking, they start to panic. 'Cause
Yeah.
they're like, oh my gosh, what do I do?
Yes. Yeah. And a lot of times when people are having a panic attack or they're very anxious, they're sensitive to what other people are feeling. And so then they might even feel more anxious as a result, or then they start feeling bad that the other person is anxious. So yeah, trying to be as calm and patient as possible is for the best.
I was just gonna maybe take a moment to share and add on to what Matthew just shared. So the anxiety that would worsen is part of that function of amygdala, which is our stress response system, and our executive function, or that smart brain, is the prefrontal cortex. So having that grounding gives us that step back to be able to use our smart brain or that executive function to make that logical and that more intuitive decision, rather than that stress response where you straight go to that anxiety, worsening it. So it's very related what we talked about.
Mhm.
Well, it may not sound such, but yeah.
Tim, you wanted to take over?
Yeah, we often talk about an epidemic of loneliness in the country, especially in the elderly. And yet, when you look at depression versus loneliness, loneliness is typified as being a transient state, whereas depressive episodes tend to be longer term. Is there some point where loneliness becomes its own, if you will, unique form or driver for depression?
I'm gonna feel like this is a cop-out answer. A lot of my things I say, it depends. I would think that it very well could be. I think a big part of with that loneliness and when it comes to a lot of the mental health conditions is it causing distress and dysfunction. So is this someone that's more of a loner as opposed to someone who's lonely? So do they kind of prefer that solitude? They prefer not having other people around them? And if it's not causing them distress and dysfunction, it might not necessarily be its own kind of form of depression. But that loneliness and that isolation can very much be the kind of triggering event or long series of events that puts someone into a higher risk of depression or having even some of that learned helplessness that I was talking about. Maybe they have tried several times in the past to engage with other people, or it has become harder as they've gotten older and things around them are changing. So interacting with people is more difficult, and they almost come to accept that they're lonely, and that puts them in this state of depression. And so, yeah, I would say it's certainly something that could lead to a different kind of pathway for depression than maybe is the more typical or stereotypical kind of cause.
Thank you. Nicole?
Dr. Agarwal, could multiple episodes of TBIs put one at higher risk to develop SUD?
Wow. I don't know. Those are really good questions. I'm gonna read up, but I don't know if TBI specifically could cause a certain brain parenchymal change that would put them at higher risk per se. Yeah. I
Yeah,
don't know.
we have so many questions, so I'm sure there's lots of good ones.
That'd be a good one. Yeah. I'll make note of that.
Okay. Mr. Lin, does anxiety show up as irritability and anger? When should, I guess it's like a multi-parter, when should one seek to be medicated? And I guess does anxiety and depression usually run hand in hand? So it's multi-parter.
Yeah. So anger and irritability can absolutely be a symptom of anxiety. Generalized anxiety disorder, on that criteria that I listed, irritability is a big component of it. And if you think about it, if you're very overwhelmed by all of these worrying thoughts or these fears or this apprehension, you're probably more likely to get irritable. Or you're so frustrated that things aren't going a certain way, or you're so afraid that things are not going to turn out well, that you're more prone to that irritability, and it can turn into anger. In terms of when to seek medication or help for that, depends on the individual. I'd say if it's, I'll go back to that distress and dysfunction. If it's impairing your day-to-day activities or near day-to-day activities or your relationships with people, I think it's worth at least exploring some kind of help. And then honestly letting whoever is evaluating you kind of determine, does this seem like something that is better managed with therapy, better managed with medication, or with both? I'd say first time when someone presents for that, either one is usually a fair option, therapy or medication. As I said before, generally the combination of the two can come up with better results than either one on its own, but sometimes access to finding a therapist can be hard, or finding one that you really have a good rapport with can be hard. And so a medication might be easier. But on the other hand, some people don't want to take a medication. They don't want to wait the 4 to 6 weeks, or they don't want the side effects of it. And those are all valid reasons. But I'd say going to seek some kind of help or evaluation first, whether that be like your general practitioner, your primary care doctor first, and kind of letting them give you some recommendations would be a good place to start.
Nicole?
Yes.
I was just going to hop back to that question on TBI.
Oh.
Did a quick review of PubMed literature just to see what research is out there. I guess the question could be answered in two ways, but with people who have had TBI, the risk of substance misuse increases because of TBI-induced chronic pain or other mental health conditions. So it may be unclear if the TBI itself is causing them to be at higher risk, or the subsequent, sequelae of the TBI, such as chronic pain and mental health, like depression, anxiety,
Right.
the diagnosis itself of TBI. But I guess in general, if we speak, then yes, there is an increased risk.
Well, thank you for finding that so quick. I guess back to Dr. Agarwal. So I guess this is in respect to addiction. They said what % of people that are treated are cured or substantially improved?
Mm-hmm.
And then I'm guessing this is going to be without insurance, but then the second part of it is, what is the average cost to treat or improve addiction? But I feel like that's a hard question to answer, the second one.
So pretty broad question, and I believe if we recall from the slide where we shared some of the data on like prevalence and the treatment, 6% and less than 6% receive any kind of treatment. So the results of those treatment vary depending on the quality of treatment and the continuity of the treatment, because like any other chronic condition, high blood pressure, diabetes, depression, substance misuse is also a chronic condition. So the continuity of treatment is essential to attain some level of success in treatment, or so to speak, remission in the condition. And it's very variable depending on the substance and depending on the continuity. The cost itself is somewhat more harder, like it's an insurance based process, so we don't really know what the actual cost to an individual would be. But I do believe that many, or for the most part, all substance misuse conditions are well covered by the insurances in Delaware and the Medicaid of Delaware.
Yeah, and I bet it also differs based on what type of treatment you are receiving. So that can also.
Yeah.
Okay, Mr. Lin, as seniors are prone to Alzheimer's and or dementia, does anxiety increase because of them, or do they increase, or does, I guess, the dementia symptoms increase because of the anxiety? It's a weird chicken and egg again.
So there can be disturbances in behavior and mood and anxiety as a symptom of Alzheimer's or other types of dementia. We see that very often with like mood and depression, I would say. In fact, sometimes if someone who is elderly is struggling with depression and they're not responding to conventional treatments, we sometimes do wonder, is this maybe some kind of dementia or Alzheimer's disease? When it comes to anxiety, I would say that is more of a, I mean, they could also have co-occurring anxiety. I mean, I spoke to an elderly woman today who has both. I treat her for anxiety and she has Alzheimer's as well. But that was something that she had prior to, and that's not necessarily something that would have caused that. Although that being said, there is some literature that does talk about exposure to benzodiazepines, especially over long periods of time or in advanced age, increasing the risk of dementia development or worsening certain outcomes in dementia because of the delirium that it can cause as well.
Oh, I also wanted to mention, Mr. Lin, there was a comment. Someone said that they appreciate the term co-occurring.
Oh, okay.
Or like comorbidities and different types of terminology. They really like that.
You're welcome.
Dr. Agarwal, if someone is dealing with chronic pain, is being treated with opioid, I guess, or other pain medication, are they more susceptible to becoming addicted to those said pain medications?
Yeah, this is frequently asked and sometimes misperceived in clinical setting, where someone who has a true chronic pain condition and is being prescribed opioids may be considered to have a substance misuse, but that is not true, and I'd say that is not always true. The reason is our body would still have the physiologic response, which is the tolerance and withdrawal to that substance, as we were discussing some of the factors or criterion in the development of a use disorder. So there is still tolerance and withdrawal because those are physiologic responses or the physical body's responses to that medication. But truly, they're taking that medication as prescribed, and they are not misusing that medication. And as long as they continue to see their clinician and maintain their prescription and maintain their lifestyle as they have been, I do believe that there's less risk. In some cases, when the pain may not be addressed appropriately with that medication and they do seek out more substances, or they may start to use more of their prescription, there may be risk of developing a misuse.
Thank you. We had a question, I guess, Mr. Lin or whoever feels this is a good question for them. Will pharmacogenics become more frequently used to better I guess, prescribe the right medicine for people?
I think that's something that Dr. Agarwal and I could both
Yeah.
probably answer.
That sounds like whoever wants to take it.
Yeah.
I would say that the hope would probably be that it can. I think it's still in the early stages. It doesn't do exactly what I think a lot of people think it does. So what I think that they're asking is about the pharmacogenomic testing, where people have like a DNA test that essentially then comes back with a report of how, based on their genes, they may respond to different medications. What it primarily does is it gives us some overview on how sensitive to medications they may be. And so that might help us dictate, okay, this medication might be more likely to cause side effects, or this one, we might have to get to super high doses to ever get to a good effect. So maybe we try these ones based on the interaction between their genetics and their, and the specific medication. But it's not perfect, and it still doesn't really tell us like this medication will work. It just helps kind of narrow down the choices a little bit. But I don't know, Dr. Agarwal, if
Yeah,
you want to add to that.
That's perfect answer. I can't add a word to it. I mean, the additional information, I guess, is that, you know, pharmacogenomics, just like Matthew explained, is what it is. There is a significant body of research that is now going into the genetic understanding of psychiatric conditions, including substance misuse. So as we speak, I mean, there are genetic loci, we call the genes, actual genes, which are being understood and identified, which may have a role in certain conditions, behavioral health. So in the future, yes, there might be a time where we could have that targeted approach towards treatment. But right now, the answer is what Matthew shared. Yeah.
Well, again,
It would definitely be easier for us and for everyone if we had, if we were able to do that. But it's not there just yet.
Yeah.
well, I guess probably have time for one more question. I guess Dr. Agarwal, since you can, I guess, wrap it up with the last question.
Sure.
I guess the main one that this person was trying to grasp is like, what is the difference between someone considered a functioning substance user and one that is considered an addict? And would their brain still show the same?
Very good question. I like the audience. These are amazing questions, you know. So when you say a functioning substance use using individual versus someone who has an addiction, there are people who may keep their job and they may pay their bills and they may still be living with their family, but are using, let's say, alcohol, for example, very commonly used at a heavier level. They may not get a DUI, because they didn't get caught, but they are still risking some of their behaviors by virtue of their alcohol use, and which would be more significant than, recreational use, as we may define it. When we say that, or if someone does identify that it's their use is more functional use, I believe they may be denying their condition, and maybe at the point of time where they are sharing this, they may have not gotten to the point where they may start to experience the impact from their substance use. So what I would say is it might catch up to them, and they may then have consequences from their substance use.
All right. Matthew, returning mini-med scholar.
Yeah.
Thank you both very much. There were so many questions we didn't do, and I hope everyone understands we did our best. Next week, we're going to be learning about endocrine disorders from Dr. John Donnelly and from a medical school fourth-year resident. So join us on May the 1st, and I'll be a little bit more dressed up than normal because this will be happening simultaneously with our annual meeting, and I'll be running back and forth between mini-med duty and doing this, as will Nicole probably. So anyway, thank you all very much. Have a great evening. See you next week.
Thank you for having us. Good night,
Thank you.
everyone.
Take care.